Dr. Maureen Mason here. Today we're going to look at a 3D analysis of the pelvis, the muscle function, and pelvic physical therapy, and how many different things impact pelvic function and pelvic health. Let's get started. I want you to meet Ruby. She's our model today, and we'll look at her bones and her muscles, and we'll also meet Ray with a side view of the pelvic muscles and the organs. First thing we want to look at from a rehab standpoint is how a person walks and moves. If I'm like this a lot, I'm putting pressure down into my pelvis, and I may have pressure on my bladder, I may have some back pain, and I may have stiffness in all my muscles of my trunk. That's going to put pressure down into the pelvis, which could be associated with back pain, hip pain, pelvic pain. On the other hand, if I'm all loosey-goosey and my muscles don't really hold well, and I can bring my pinky way back, I can touch my thumb to my forearm, I can hyperextend my elbows, which I can't, but if my elbow went beyond this. Some people have ligamentous laxity. The knee can go back way beyond 180 degrees and have laxity there. Ligamentous laxity can cause problems in the pelvis because things aren't supported. Okay, so looking at gait, we can also look at athletic function, the ability to lift, push, pull, carry, dance. These are all functions where the pelvis has to shock absorb for bladder and bowel control and also for stability. So having a strong back, strong abdominals, strong hip muscles, outer and inner, and a strong pelvic floor, but also elastic, these are important for athletic functions. If things are too tight, sometimes people leak, athletes might leak because they're actually too tight in the pelvic floor. And if things are too loose in the pelvic, if those Kegel muscles aren't grabbing when we lift, push, pull, or jump, sometimes people can leak with that too. Let's go into a little more 3D analysis. I've always thought of the pelvis looking like a bird, but we can also look at it like an axle. It gets us along, stepping. We have three major bones of the pelvis. We have the ilium bone. I want you to feel right now, reach down and press down. That's your ilium bone. This is a shelf. There's an anterior iliac spine here, which is a point of muscle attachment and also the inguinal ligament that arteries and blood vessels go under and muscles. Inguinal ligament is kind of a transition between the ilium and the pubic bone. The pubic bone is joined in the center by the symphysis. Normally this doesn't move much. There's a few millimeters of rotation between these bones in most people for shock absorption. In pregnancy and childbirth, sometimes there's too much laxity here and people need to do a lot of exercises and watch their posture and alignment until things tighten up again. That's the pubic bone, ilium bone. And then the ilium bone joins in with this lower bone of the pelvis, the ischium bone. This is called the ischium. And we have the hip socket here. The ischium has the main landmark of the tuberosity. You're looking at a back view of the pelvis. Here's the back, here's the belly. These are the tuberosities. The tuberosities are a landmark for where the hamstring attaches. We also have the inner thigh muscles, adductors, attaching into that area, as well as into the pubic bone. The gluteal muscles also attach back here, and many ligaments. Why is the ischial tuberosity important? It's a landmark in pelvic therapy because we have a transverse perineal muscle that goes across there. And then around the pubic bone, we have this ischiocavernosus coming down on either side, urogenital triangle for the urethra and the genitals. There's three muscles of the urogenital triangle I want you to know about. These are the Kegel muscles people think of. This is a female model. This is showing the urogenital triangle with that ischiocavernosus, transverse perineal, and then bulbospongiosus. It's a sphincter muscle in the center. There's a female urethra, and then here's the vaginal opening, Then there's the perineal body, which is an intersection between urogenital triangle and then the superficial anal triangle, which houses the external anal sphincter. Superficial pelvic muscles, superficial kegels, all part of sphincter support for our organs. They also have to relax and release for elimination and intimate functions and birth. Here's a deeper view of the pelvic, which you were already looking at for the tuberosities. Imagine a sheet of saran wrap and a whole bunch of sheets of saran wrap going in different directions. That's called the second layer. Beneath that urogenital triangle muscle, the superficial, with the diaphragm, pelvic diaphragm, it's a fascial zone of connective tissue support for the urethra, for the prostate, for the external anal sphincter. And it's just a dense layer of support in there. Then we get to the deepest layer here. We look in the bowl of the pelvis. This would be the belly. This would be the back. We see this big loop of muscle going back to the tailbone. We have puborectalis, pubococcygeus, iliococcygeus, and ischiococcygeus, all different muscles of what's called levator ani. The levator ani complex does what you might think. It keeps support deep inside for the pelvic organs, and it blends in with a bunch of myofascial connections into the rectum and the external anal sphincter. Some people have spasm in the levator ani. They can have a levator ani that's too tight. They can be clenching all the time. Sometimes when people are trying to eliminate, they might be tightening too much and not have ease of elimination. So levator ani, its job is to support and hold, and it's also needs to relax for functions as I described. Pelvic physical therapy evaluates the tone in the muscle. We look for tender and trigger points. We look at the function of contracting and relaxing, and in relation to the organs, are they being supported? We look at it in relation to bladder function, into bowel function, and intimate function. So ideally, people have control over their primal functions and they don't have any pelvic floor problems, but over 70% of women actually experience urinary leakage. That's one of the biggest things, because females have lighter support of the bladder compared to the males. Female bladder is more lightly supported in the front wall of the pelvis. Here's a pubic bone. Bladder sits behind the pubic bone, and the urethra runs down the front wall of the vaginal column. Here's a view of the uterus, and we can picture the uterus sitting on top of the bladder. And those are the pelvic organs. They're all nestled down into the bowl of the pelvis. And with changes in the uterus, pregnancy, birth, even difficulties with menstrual problems, dysmenorrhea, endometriosis. Sometimes there's a lot of bladder irritability and bladder problems. So the uterus and the bladder are buddies. And then we can look at inside the male, why males don't have much urinary leakage. We can look at a side view here of the male anatomy, and we can see the urinary bladder. We can see the prostate gland. We can see a thin line demonstrating the pelvic floor muscles. This would show the pubic bone here. This is showing the rectum in the back. And males have a tight shutoff valve at the neck of the bladder due to the prostate gland. Sometimes when the prostate gland starts swelling, men have urgency and frequency, and they're getting up so many times at night. And then, of course, sometimes we have prostate cancer there. Usually, oncology treatment is not warranted these days. They're doing less intervention for surgery and radiation, but sometimes it's certainly needed. Side effects of that can be impotence, it can be urinary leakage, and sometimes pelvic pain too. So that's Ray, that's our male model. More to come on that. And we will be coming back to Ruby in future videos giving you more information. One more thing, one more tip, is that if we're coughing a lot, if we're bearing down a lot, pressure down into the pelvic bowl can cause pelvic pain, bladder problems, hernias, we know about that. But suffice it to say, when we lift, push, pull, carry, we should have coordination of pelvic, respiratory diaphragm, and even our throat. If we're tensing and push down a lot, even if we're coughing a lot, if we have respiratory problems, bronchitis, asthma, frequent colds, the glottis and the larynx can be pressing down a lot into the pelvis. The diaphragm can be pressing down. Ideally, the pelvic floor muscles, the kegels, and the respiratory diaphragm work together. They move up when we tighten everything. They can move down when we relax. And for synergy, we want to be able to have elimination where we can completely relax our belly, relax the diaphragm, relax the jaw and shoulders, ease of urination, relaxed effort. And for defecation, ideally, we want to be able to firm that abdominal wall, relax the pelvic floor, and eliminate without a lot of tightening and straining. Some people have dyssynergia, where they sit down on the toilet and they're tightening instead of relaxing, and they're sucking in instead of bearing down. So they're somewhat simple things in the surface, but they actually are very complex medically on what can happen when people have defecation troubles, chronic constipation, pain with urination, urinary hesitancy, urinary incontinence, and then finally pelvic organ prolapse is when, usually associated with childbirth, the bladder is pushed down a bit during pregnancy, and then it might start to come closer to the vaginal opening. That's pelvic organ prolapse. Same thing, the uterus, which is really shaped like a pear, the uterus can start to slip down a little bit and move down towards the vaginal opening, and then even the rectal area can start with some downward pressure in men and women into the pelvic bowl. That's called rectal prolapse, different than having hemorrhoids, but sometimes that will cause an inability to completely eliminate with ease, and need to see gastroenterology, urology, other medical specialties. Pelvic physical therapy looks at your abdomen, back, hip, all these functions, and looks at your Kegel or pelvic muscles to help you optimize your health, have a home program of lifestyle habits, nutrition, exercise, pelvic floor relaxation, and or pelvic floor tightening protocols as you might need. Usually in pelvic pain, we avoid a lot of pelvic tightening, but some individuals may benefit from a light contraction and relaxation of the pelvic. So there's not a cookbook for pelvic physical therapy or Kegel exercises. Now you understand more about your surface muscles, that urogenital triangle and that anal triangle. You understand there's a middle layer there that supports, and you understand this concept of this deeper bowl of the pelvis, the levator ani, that supports everything, and ideally works well with a respiratory diaphragm, vocalization, control of breath, control of tightening and relaxing as needed for daily habits, so that people can live pain-free and with joy. Thanks for listening. More detail in another video where we'll look at some detailed graphics with more terminology for your elucidation on pelvic floor muscles, fascial membranes, the nerves, and the blood flow in relation to pelvic health and pelvic health challenges. Maureen with Central Station Well. If you want a lot more info on the topic, you can get my book, The Pelvic Rehabilitation Guide Across the Lifespan, by myself, Maureen Mason, published by Handspring Publishing, and also on Amazon.